Good morning and welcome to our monthly teleconference series. Today's topic is bone health, brought to you by Northern Westchester Hospital Center for Healthy Living. My name is Margaret Robato and I'm a registered nurse and educator for the Community Health Education and Outreach team. I'd like to introduce Dr. Rita Landman, MD, FACE. She's an endocrinologist with Westchester Health with a clinical focus in general endocrinology, diabetes, thyroid disease, osteoporosis, and women's health. She received her MD at New York University School of Medicine. Let's get started with the presentation. Welcome, Dr. Landman.
Thank you very much, Margaret. Thank you for having me. I'm going to talk to you today about osteoporosis. So what is osteoporosis? Osteoporosis is a disorder of the skeleton characterized by low bone mass and a disruption in bone architecture, which leads to weaker or more fragile bone, making the bone more likely to fracture. Now, how does one know if one has osteoporosis? So osteoporosis can be diagnosed clinically based on the presence of a fracture, or what we call a fragility fracture. Now, what does a fragility fracture mean? A fragility fracture is defined as a fracture that occurs either spontaneously, for example, during coughing or opening a window, or after falling from a standing position. Now, this is opposed to a traumatic fracture, which can occur, for example, in the setting of a car accident or falling down a flight of stairs. If you're walking down the street and fall and break a hip or wrist, that is called a fragility fracture. The other way to diagnose osteoporosis in the absence of a fracture is based on a bone density. Now, one thing that's important to know is that the clinical symptoms of osteoporosis really occur only if a fracture is seen. Aches and pains are not symptoms of osteoporosis. Aches and pains may indicate muscle aches or joint aches or osteoarthritis or tendinitis, but that is not osteoporosis. Now, who should be tested to see if osteoporosis is present? Because a lot of people have osteoporosis even if they haven't had a fracture. So basically, osteoporosis is more likely to happen as we age. So all women over the age of 65 should have a bone density test to test for osteoporosis. And I'm going to tell you a little bit more about the bone density test in a little bit. Women younger than 65 but over 50, as well as men over 50 who are at higher risk for osteoporosis, should also be tested. Now, what are the risk factors for osteoporosis that should signal one to get a test? That would include somebody with a family history of osteoporosis, such as somebody whose family members have fractured a hip specifically, somebody who smokes cigarettes or drinks alcohol in excess. Those are risk factors for fracture and osteoporosis. Somebody who takes certain medications, such as steroid therapy, also things like height loss, low body weight, and early menopause. There are other disorders, rheumatological diseases, parathyroid disease, malabsorptive issues, but some of the ones I mentioned are the most common. So how does one get tested for osteoporosis? So the test we use is called a DEXA test. It's the most widely used test to look at the bone density. And it actually measures the density, which is the bone mineral content in grams divided by the area. So with the bone density test, we get a density at the lumbar spine and the hip, and sometimes the wrist. And what is assigned is something called a T-score, which is one looks at the actual density compared to young women or men at their peak bone mass, which is in their early 30s. And we do a standard deviation calculation that results in a T-score. And that's how we define osteoporosis based on a bone density. So if a T-score is less than -2.5 or worse, that signifies osteoporosis. There's also a category called osteopenia, which is mild bone loss, but not yet at osteoporosis, where the T-score is between -1 and -2.4. So if you've had a bone density and you have been assigned a T-score, that can be used to define either normal bone density, osteopenia, or osteoporosis. And just so you know, a bone density is a test done at a radiology facility. It involves very little ionizing radiation. It's not scary. It involves lying down and again, looking at the bone density at the spine and then the hip and sometimes the wrist as well. And the bone density has been shown to be very valuable in predicting fracture and choosing patients who are good candidates for therapy. So, let's talk about how to treat osteoporosis if it's present. And let me go back just one more minute. What is the whole implication of having osteoporosis? If osteoporosis is present, then that means that your risk of fracture during your lifetime is higher. And so we want to treat the osteoporosis to prevent fracture. If we had a crystal ball and knew who would fracture and who wouldn't, that would be easy. But in general, as we get older, when the T-scores get lower, the fracture risk is higher, and we want to be aggressive in preventing fracture. So we start with lifestyle modification. So think of bone. I always tell my patients, think of bone like skin. It's building up, breaking down, building up, breaking down. And generally over time, the breakdown process occurs more rapidly than the buildup process. And that's how we get to osteoporosis. But certainly we need to have the building blocks of bone, which would be an adequate calcium and D. So the recommendation for calcium intake in a postmenopausal woman is 1,200 milligrams of calcium per day. And the best way to get calcium is through the diet. The most common source of calcium in the diet is dairy, where generally each serving of dairy is about 300 milligrams of calcium. So that may be a glass of milk, a serving of yogurt, an ounce of hard cheese, 8 ounces of cottage cheese or ice cream. And then there's certain sources that are fortified. So for example, you can find in the grocery store orange juice that has been fortified with calcium and D, and that has as much calcium as milk. Soy milk and almond milk are typically fortified and have as much calcium as cow's milk. There's certain cereals, such as Total cereal that has 1,000 milligrams of calcium. A lot of my patients ask me, what about dark green vegetables? So leafy green vegetables that do have calcium, not so much. It's very hard to get all of your calcium from green vegetables. Most people say that with a healthy diet, you get about 300 milligrams of calcium from green leafy vegetables. So then you want to have about 2 or 3 sources of dairy. Now, if the calcium cannot be obtained fully from diet, that's when we add calcium supplements. So as far as calcium supplements, there's 2 main sources of calcium supplements, calcium citrate and calcium carbonate. Calcium carbonate does require acid for absorption, so calcium carbonate should be taken with food. Calcium citrate does not require acid for absorption, so it can be taken on an empty stomach. Now, there's a lot of individuals who suffer from acid in the stomach or reflux disease and take antacids, things called proton pump inhibitors, such as Prilosec. These medications have terms like omeprazole or pantoprazole. If these medicines are taken, then calcium citrate is the supplement of choice. The other key about supplementation is that it's hard for the body to absorb more than about 500 milligrams of a supplement at once. So if one is needing more than that, then it should be taken in divided doses. So something like 500 milligrams twice a day. What are the side effects of calcium supplements? Constipation is by far the biggest side effect of calcium supplements. One can also get some bloating. Calcium citrate may be a little better tolerated than carbonate, but generally constipation and bloating are the toughest. And in excess, calcium supplements can cause pain. Now, I have a lot of patients who say to me, I have osteoporosis, but I'm afraid of medications. I'm just going to double my supplements. That does not do anything for you and can be harmful. So the recommended amount is 1,200 milligrams a day. You don't want to exceed 1,500 milligrams a day, and taking more can only increase your risk of side effects. Let's talk a little bit about vitamin D. Most of us do need vitamin D supplements because in the sun, we put our sunscreens on. The sunscreens prohibit, block vitamin D synthesis. And most foods do not have too much vitamin D other than things like cod liver oil. So vitamin D is typically required. It might be 800 units a day or 1,000 units a day or sometimes more to get adequate vitamin D for those bone building blocks. Vitamin D is something that people do also take in excess, thinking like, vitamin D is now the cure-all for everything. It's kind of a hot vitamin these days, but one can overdose in vitamin D, which can then lead to high calcium and kidney stones. So you want to have the recommended amount of vitamin D. You can ask your doctor to measure it if you're worried about osteoporosis, but not in excess. Now, calcium and D deficiency can cause worse bone density and osteoporosis, but generally if osteoporosis is present, calcium and D are not enough to prevent fracture. Some studies show that calcium can increase the bone density slightly, but there's not evidence that calcium and D alone can prevent fracture. So we'll move over to medication soon, but I don't want to forget a few other things. So exercise is recommended, and exercise can improve bone density modestly, but very importantly, exercise has been shown to reduce fall risk. And most fractures occur in the setting of a fall. So exercise is very important. The recommendation is for 150 minutes of weight-bearing aerobic exercise per week. Weight-bearing exercise is what we do when our feet are on the ground. So something like walking, jogging, walking upstairs, hopping, skipping, low-impact jumps. These all qualify as weight-bearing exercise. Strength training twice a week is also recommended, as well as balance exercise. We want to remember things like smoking cessation if somebody smokes, because that increases the risk of osteoporosis. Avoid heavy alcohol use. And let's also remember checking the home environment to reduce falls, anchoring rugs, removing loose wires, using non-skid mats, installing handrails in bathrooms and hallways, keeping entrances well lit, and also encouraging using, wearing heels that are sturdy. Okay, sorry about that. Let's talk about medication. So when is medication warranted? Basically, medication is warranted if the risk for fracture is high. That would be if somebody has had a fragility fracture, particularly if someone has had a fracture in the last year, the risk for another fracture is very high. And certainly anyone with a vertebral fracture or a hip fracture should be a candidate for medication. In addition, if a T-score of less than -2.5 is seen on the bone density, putting someone in the category of osteoporosis, medication is warranted. In addition, if somebody has osteopenia on a bone density, we now do what's called a fracture risk analysis using what's called a FRAX calculation. This is something that's part of the bone density. We look at other risk factors for fracture, and if the risks for fracture are high, medication is warranted. So medications get a bad rap for osteoporosis, but they really have all been shown to not only improve bone density, but reduce fracture in order to be an FDA-approved medicine for osteoporosis. The first line drug is typically the oral bisphosphonates. These are the most widely used because they've been around since the 1990s. They are generally generic and available at a lower cost, and they're efficacious both in terms of improving bone density and, importantly, reducing fracture. And we have long-term safety data. These work by preventing bone breakdown. They're taken in the morning on an empty stomach with a full glass of water, sitting upright, waiting at least 30 minutes before taking other medications or eating. And that's because they're hard to absorb, and also because we want to get those pills past the GE junction, past the esophagus into the stomach to avoid the most common side effect, which is esophageal discomfort. The main side effect of these oral bisphosphonates is esophageal discomfort. The other main side effect is muscle or joint ache. And muscle and joint aches usually resolve when the medications are discontinued. Excuse me for 1 second. Okay, sorry about that.
That's okay.
So those are the most common side effects. Just so in case of bisphosphonates include things like alendronate, tendronate, abandronate. Other terms for these medicines are Fosamax, Actonel, Boniva, and these are the oral bisphosphonates. The nice thing about these medications, we typically use them for 5 years, and then we know that when we stop them, they continue working to prevent fracture for another 3 to 5 years. So we don't have to take these medications forever, and that's kind of nice, especially in a young woman in her mid or late 50s, in their 60s. This isn't something we have to take forever. They're contraindicated in people with esophageal disease or malabsorption, or if there's reduced kidney function. In individuals with esophageal disease who cannot sit upright, there is an intravenous infusion in this family called zoledronic acid or Reclast. This is a really nice medication that's given by infusion just once a year. So you take it once a year and then you're done for the year. It's given every year for 3 years. And then again, there's a drug holiday. What are other medications that are available? I'm not going in any particular order, but there's a medication called denosumab, also known as Prolia. This is a stronger medication that's also used to prevent bone breakdown. It's given by subcutaneous injection every 6 months. And one of the nice things about this medication is that it can be used in our individuals with kidney disease, where the bisphosphonates cannot be used. It has few side effects. It can also cause some muscle and joint aches. It can cause low calcium, really in someone who's at risk for that. And sometimes there can be a little bit of a skin rash. It is different than the bisphosphonates. It has to be, when this medication is stopped, we can see a fairly quick loss of bone density. So in general, let me go back a little bit. Denosumab has been used safely for up to 10 years and has been shown to very strongly improve bone density and prevent fracture and to be safe for 10 years. However, in the last few years, we've learned that when this medicine is stopped, the bone density can decrease rapidly and one is at risk for vertebral fractures. So what we now do is when we're ready to stop the denosumab, we go back to our first category of medication, the oral or IV bisphosphonate. We give that medication for a year. So what we think of is sort of sealing in the changes, and then we take it to the holiday. Another option is something called raloxifene or Vista. This is a daily medication. This is also something that we give to prevent bone breakdown. It's weaker than the other two medications, but it has been shown to improve bone density at the spine and hip and prevent spine fracture, but not hip fracture. It is weaker, but one of the nice things about this medication is it's actually been shown to reduce breast cancer risk in women at high risk of breast cancer. So there's a population of people who cannot tolerate or cannot take a bisphosphonate or the denosumab, who are high risk for breast cancer, where here we can both prevent spine fracture and breast cancer, and it can be a nice option. The main side effect of raloxifene, also called a Vista, is it's called an estrogen receptor modulator. It has some properties of estrogen, which here include a high risk of blood clots. So in somebody at risk for blood clots, we don't use this medication. The last category of medications for bones are what are called anabolic medications. These are medications that build new bone. These are generally given for more advanced osteoporosis, people with a T-score that's even worse than -2.5 in the 3 range, or somebody who's had repeated fragility fractures, particularly of the spine. These are medications that are given by injection. There is teriparatide, also called Forteo. There is abaloparatide, also called Tymlos. These are parathyroid analogs, and they're given daily by subcutaneous injection for up to 2 years. They are strong in building new bone and preventing vertebral fracture. They're generally well tolerated, but can cause a little bit of nausea or low blood pressure when it's first used. These medicines have been shown to cause a type of bone cancer in rats who are treated with high doses. We do not see this in humans, but this is why we only use the medicine for 2 years. And we don't give this medicine to anyone who's at high risk for bone cancer, which is mostly going to be someone who's had a radiation in the past. When we stop this medicine, the bone density usually does decline. And again, we go back to either our bisphosphonate or denosumab, and then we stop that medicine for a drug holiday. The newest kid on the block is another anabolic called romosozumab, also called Avidity. It's used every 6 months for every month for a year. It has an even better bone density response than the other ones I mentioned, but it's new. It's only available since 2019, so I haven't used too much of it. And in one of the studies, there was a higher risk of heart disease, heart attacks. So we're still learning about this medication, but it is very robust in terms of its bone density and fracture prevention. Okay, so I'm going to stop now for questions, and we'll go from there.
Terrific. Thank you so much. That really is great information. And so I do have some questions, like you had said, that were previously submitted from the audience. So first one, oops, I apologize. I just lost it. 1 second. The first one is, some doctors say calcium and magnesium are required when on Evista. Others say calcium can cause heart damage. What is correct?
Okay, so before I get back to the calcium, I'm just going to mention magnesium. Most people get enough magnesium through their diet that they do not need magnesium supplements in general, whether it's for osteoporosis or something else. The exception is people who drink excessive alcohol or have chronic liver disease, and people who take certain medications. Sometimes long-term diuretics or proton pump inhibitors can lead to magnesium deficiency.
Mhm.
If that is not the case, if the body has enough magnesium, which is the majority of people, magnesium supplementation is not necessary to either absorb adequate calcium or to increase bone density. And that's with people who take a Vista or anybody. Regarding calcium supplementation, we talked a lot about it, but there is a lot of questions about calcium and heart disease. Because some people think, well, if I get a lot of calcium supplements, will that calcium supplementation lead to deposition of calcium in my arteries?
Mhm.
And first of all, I want to say that there has never been any link between dietary calcium and coronary heart disease, never. But there are some studies that look at calcium supplementation and heart disease, and it's really not clear. Most of the studies do not show a link between calcium supplementation and heart disease, but some of them do. In the studies that have shown a link between calcium supplements and heart attacks, the studies, to be honest, were not great studies. They're either small studies or the calcium in those studies were used in excess, over 2,000 milligrams a day, or heart attacks was not a primary outcome. So the heart attacks were not necessarily verified, but it's something that we still worry about. Again, the recommendation would therefore be to try to get all of your calcium from diet. And if you can't, supplement the amount that you need, but avoid calcium in more than 12 to 1,500 milligrams a day. And that applies to someone on a Vista or on any medicine or in general.
Okay, great. Okay, can certain bone prescriptions or injections lead to possible problems with the jaw?
Okay, so there is a phenomenon called osteonecrosis of the jaw. Generally, what happens is after an invasive procedure, an invasive dental procedure, but there can be sort of exposed area of bone in that area of the jaw, the maxillofacial area that don't heal. This can occur in general, very rarely, in people who especially have risk factors for this condition, which include a history of cancer, diabetes, radiation to that area, or steroids, but has also been shown to occur at a slightly higher risk in patients with osteoporosis without medication and in patients who take certain medications. And almost every medication I have listed, with the exception of those anabolics, can cause osteonecrosis of the jaw. A thing to remember is it is exceedingly rare. So the risk of osteonecrosis of the jaw, for example, in someone who takes oral or IV bisphosphonates, is between about 1 in 10,000 and 1 in 100,000. The risk in patients on denosumab is about 5 cases per 10,000. So, and this has even been shown with the newest one, the Avinity or romosozumab. So it's very rare. It shouldn't dissuade you from taking medicines if they're needed. The best thing that's recommended is to maintain good dental hygiene because that reduces the risk overall. And often if we're going to be starting the medicine, we'll say, in addition to seeing your dentist every 6 months, check in with your dentist. If you have an invasive procedure, maybe get it over with before you're going to start these medications.
Okay, great. Do you have any information to offer people with rheumatoid arthritis?
So individuals with rheumatoid arthritis are at higher risk for osteoporosis in general, and at a higher risk for osteoporosis as well as osteoporotic fracture compared with individuals without rheumatoid arthritis. And it's both likely due to the underlying condition, perhaps the inflammation associated with arthritis causes inflammation in the bone, and also the immobility we often see with osteoarthritis, immobility we often see with rheumatoid arthritis, as well as the medications we use to treat rheumatoid arthritis, such as steroids. Because individuals with RA are at higher risk for osteoporosis, bone density is very important. And your rheumatologist will know how to interpret the bone density T-scores. And rheumatoid arthritis is actually built into our FRAX calculation. So if osteoporosis is not present by T-score in the setting of osteopenia with rheumatoid arthritis, we're often going to recommend medications in general. So the bottom line is we often recommend medications for osteoporosis in someone with RA sooner than we would in someone without RA. And again, it's just important to be sort of more aware of bone health. Sort of a separate topic, there are certain osteoporosis medicines that have been approved in steroid-induced osteoporosis. These are the bisphosphonates, as well as teriparatide. So it's a whole other category of discussion, but the bottom line is think more that so you are at higher risk of osteoporosis and fracture and prevent as much as you can and be on top of bone densities.
Okay, great. This question says, I am in my 50s and I just recently started noticing that I hear and feel a popping sensation in my left knee, but I don't feel any excruciating pain. Could this be a sign of bone density loss or bone deterioration?
So generally the answer is no. I'm not a rheumatologist or orthopedist, but it's very likely that that sensation in the knee, if it means anything, represents perhaps some osteoarthritis, which is actually not at all related to osteoporosis. Again, I have a lot of my patients who will say, oh, I have osteoporosis in my hip. That must be why I'm achy. That's not the case. Pains in the joints are due to osteoarthritis. There can be some tendinitis or other inflammations. But again, with osteoporosis, the only clinical symptom is going to be a fracture. And a fracture can absolutely cause pain, but pain in the absence of a fracture is not osteoporosis.
Okie doke. Which treatments are best for osteoporosis patients in their 70s, especially weekly Fosamax? And how many years recommended to take before the side effects may be worse? I'm sorry, I read that it was written, it wasn't quite clear. So which treatments are best for patients with osteoporosis in their 70s?
So there's no medication that's necessarily better or worse at certain ages. I will say the one exception is probably the raloxifene or Vista. This is the estrogen receptor modulator that does increase one's risk for blood clotting. And because things like stroke occur more frequently as one ages, there's a lot of physicians who won't use a Vista as people get into their 70s. And again, a Vista is raloxifene. Short of that, all of the other medications are used in people at all ages after menopause and sometimes before menopause. And the one thing I will say is that age is an independent risk factor for fracture. So as one gets into their 70s, the risk of fracture is much higher. So if anything, sometimes we want to be more aggressive. But medications like Fosamax, as well as IV zoledronic acid, the denosumab, the anabolics can all be used in their 70s. Side effects are not more common as we age. And Fosamax can absolutely be used in the 70s. As far as how many years to take, one of the reasons that we give the Fosamax type drugs for 5 years and then take a holiday is because it's been shown in studies that if we give for 5 years on and 5 years off, that again, the effects in fracture prevention persist. So that's often why we stop at 5 years. The side effects such as the esophageal issues or the musculoskeletal issues are not more likely to occur with extended duration of use. But I will say the osteonecrosis of the jaw and something we didn't talk about, there's another very rare association with something called atypical femur fracture. These may occur with longer duration of use for any of these medicines. So we often stop at 5 years for the Fosamax. Again, when we stop denosumab, we finish it up with something like Fosamax. But the daily side effects are not more likely to occur with age. And again, all of these are given frequently in women in their 70s and even into the 80s and 90s.
Okay. Well, this brings us to the end of our session. I want to thank you so much, Dr. Landman, for sharing your expertise with us. And I want to thank all of you for joining us for our monthly teleconference. I hope that you enjoyed it as much as I did. Please remember to call in every month on the last Wednesday at 11 a.m. The call-in number remains the same each time. Next time on July 25th at 11 a.m., we will discuss skincare in the summer with Dr. Ross Levy, who is the Chief of Dermatology at Northern Westchester Hospital. Thank you and be well.